Good evening, everyone, and welcome to today's session. Archana, Jay Karthik, and many more who are all on the YouTube joining this audio only preparation with Dr. Murali Bharadwaz. Hi, Archana. Am I audible? You can unmute your mic and speak. Archana, are you there?
Yes, sir.
Very good. And Jay Karthik, are you there? Can you kindly unmute your mic and speak, Karthik? Yeah. Karthik, are you there? Okay. So let's make the great beginning. As I told you, PowerPoints, whiteboard, videos, they're all very boring. What is most interesting is audio only that keep you strong. All your focus, directly your ears are listening, your auditory cortex is processing, and that is sitting into your memory. And it is very easy with the spaced repetition technique. So every day evening, 6 o'clock, I'll be there to pick up 5 to 6 topics and 10-15 points about each of them, and then have a quick question answer session with you. So that is how our preparation is going to progress. So thanks this wonderful evening to Archana, Karthik, and many more for joining. So let's make the start. Let us start with today a little bit of general medicine. Let us take up. Now, let us start with the topic of Tricuspit Stenosis. First, I'm going to tell you 10 points about Tricuspid Stenosis. Number one, Tricuspid stenosis does not occur alone, but it occurs with generally with mitral stenosis. Archana, quickly tell me, where is the tricuspid valve? Between what and what? Good to see Manoj. Manoj, you are from which medical college, Manoj? You can unmute your mic and speak. Hi, Manoj. Can you unmute your mic? You can unmute your mic and speak. Yeah. Are you there, Manoj? Okay. Okay. All right. So basically, to speak, I think you all know you need to unmute the mic and speak. Anybody can speak on this forum. All right. So good to see Ankit, room number 34. Hi, Ankit. Can you say hi? I think your mic is not connected. You can connect with your mic. Great. Ankit, you are there online?
Hi, sir.
Hi, Manoj. Good. So every day evening, we'll make it an interactive session to do a revision. And generally what happens whenever we are going to any classroom, we think that we'll get a feeling that we did not prepare. How can we join a classroom in a question answer session? So that is the reason a new technique called spaced repetition. I'm going to pick up one topic, give 15 to 20 points on that quickly. And then once more, I'm going to shoot back and ask you in the form of a question and answer, which you should be able to answer. That is how we are only audio revision we are going to do every day evening 6 o'clock. So thanks to all of you for joining the session. So let's make the start. So where is tricuspid valve? Manoj, between which chamber and which chamber? You can keep unmute and speak. Yeah, can you unmute your mic? Good to see Vaibhav Anand, Archana, Manoj, Ankit and everybody. Archana, are you there?
So between right atrium and right ventricle.
Very good. Between right atrium and right ventricle. So keep unmuting your mics and keep speaking. Yeah. So that makes it more interactive. Very good to see Haripriya also joining our evening Chai Pe Charcha batch. Very good. Now, typically, what kind of axis deviation do you expect in tricuspid stenosis? Whenever there is any tricuspid stenosis, there is an increased pressure in the right atrium. And what is draining into the right atrium? It is the great veins, SVC, IVC are draining into the right atrium. And because of that, what will happen? SVC, IVC cannot drain into right atrium, and that lead to the congestion in the liver. So a pulsating liver, pedal edema, all the signs of right heart failure, that is what you get in the case of the tricuspid stenosis is what you need to basically remember. Now, typically in the tricuspid stenosis, typically, what is a very common reason tricuspid stenosis can happen? Any guess, anybody? Can you tell me one scenario where tricuspid stenosis can occur other than rheumatic fever? Any guess? Haripriya, Vaibhav, Manoj, Archana, Ankita, Ankit, anybody? Yeah. Dr. Nageshwar. So what is that condition where tricuspid stenosis, etiological factor? Anybody would like to try? Even the online students on the YouTube can also answer. So typically
Endocarditis.
in
Endocarditis.
In
Carditis.
endocarditis, very good. And typically in which subset of population right-sided endocarditis is seen? Intravenous drug abusers, we see right-sided endocarditis is what you need to remember. And carcinoid is one condition you need to remember when we talk about the right-sided, that is a tricuspid stenosis is what you have to basically remember. Now let us talk about pulmonic stenosis. Now, tell me one syndrome where you find pulmonic stenosis. Anybody would like to try? In which syndrome do you get pulmonic stenosis? In which genetic syndrome do you get pulmonic stenosis? Who is
Tetralogy of Fallot.
Yeah?
Tetralogy of Fallot.
Tetralogy of Fallot, you have pulmonic stenosis, very good. Any genetic syndrome where you get pulmonic stenosis? Typically in the girls, you have short stature, gonadal dysgenesis. Tell me, what is that counterpart of that syndrome?
Down syndrome.
Turner's syndrome. Turner's syndrome. The counterpart of the Turner's is the Noonan. And in the Noonan syndrome, typically you have the pulmonic stenosis is what you need to remember. And what is the valvular defect, the most common heart lesion that you see in Turner syndrome? Who is going to give me the answer? See, basically, if you read yourself, no, you'll get bored. But if you are being questioned, right, you are being quizzed, that is where you get all that enthu to read, remember, and reproduce. Come on, anybody of you? Vaibhav, Vidyasagar, Haripriya, Hanush.
Coarctation of aorta.
Yes?
Coarctation of aorta.
Very good. Coarctation of aorta is the second most common, but most common valvular lesion?
Bicuspid.
Bicuspid aortic valve.
Very good, very good. So, 5 important reasons for pulmonic stenosis you should remember. Number 1, Noonan syndrome. Number 2, Turner syndrome. Number 3, carcinoid syndrome. Number 4, rheumatic heart disease. These are the 4 reasons you need to remember for the pulmonic stenosis is what I want to underscore to all of you. Now, the next interesting question I like to ask you, especially with regard to the JVP, tricuspid stenosis, tricuspid regurgitation, pulmonic stenosis, pulmonic regurgitation. So these are all what? Right-sided stenotic or regurgitant lesions. In all these right-sided stenotic or regurgitant lesions, especially tricuspid stenosis, pulmonic stenosis, pulmonary regurgitation, in all these 3, which wave in the JVP will get affected and what is the effect of that wave on that wave? Anybody would like to try and answer?
Slow Y wave.
Huh?
A wave.
Very good. A wave. It is a large A wave. Large A wave is the classical thing that you see in tricuspid stenosis, pulmonic stenosis, and also pulmonic regurgitation. Then what is that classical change that happen in tricuspid regurgitation? Which part of the JVP get affected? JVP.
Y wave. Y wave.
Very good. Y descent. You get a steep Y descent in tricuspid regurgitation. That is what you need to remember. Now let us talk about the murmurs. What are the murmur of tricuspid stenosis? What are the murmur of tricuspid regurgitation? What are the murmur of pulmonic stenosis and pulmonic regurgitation? Let us start with tricuspid stenosis. Come on, diastolic or systolic, early or mid or late? Or
Diastolic.
yeah?
Diastolic.
Very good. It is a mid-diastolic murmur, just like mitral stenosis, but a right-sided mid-diastolic murmur in tricuspid stenosis. Very good. Tricuspid regurgitation, what is the murmur you listen?
It's systolic.
Very good. It is systolic. And what type of systolic it is, Vidyasagar?
High pitched.
That's right. Is it pansystolic, ejection systolic, or
Follow systolic.
Yes, sir. Ejection systolic murmur.
Always remember, pulmonic valve, aortic valve. That is the place where you get ejection systolic. Whereas AV valves are there, no? Mitral valve, tricuspid valve. At that level, what you get is a pansystolic murmur. Whenever a regurgitant lesion is there, pansystolic murmur. For example, you take tricuspid regurgitation. Why it is systolic? When the right ventricle is undergoing systole, it will push the blood back into the right atrium. That is the reason throughout the systole you listen pansystolic murmur if it is a lesion in the AV valve level. All right. Whereas in mitral regurgitation, when the left ventricle is contracting, it is pushing blood forward into the aorta and backward into the left atrium. That is the reason even mitral regurgitation also is a pansystolic murmur is what you need to remember. Now summarize. Tricuspid stenosis is what kind of murmur?
Mid-diastolic.
Very good. And tricuspid regurgitation is what kind of murmur?
Holosystolic.
Pansystolic. Very good. And pulmonic stenosis is what kind of murmur?
Systolic murmur.
Ejection systolic. I told you, na, aortic and pulmonic valves, whenever they are stenotic, they lead to ejection systolic. That is, whenever the ventricle is contracting, undergoing systole, pushing blood into the aorta or pulmonary artery, then ejection systolic murmur will occur, right? Then pulmonic regurgitation, what is the name of that murmur?
It's a type of diastolic only, sir.
It is a Graham-Steele's murmur, which is a early diastolic murmur. Graham-Steele is a early diastolic murmur of pulmonic regurgitation is what you need to remember. Similarly, there is a murmur which is there in aortic regurgitation. What is that murmur called? Austin Flint murmur, which is typically a mid-diastolic murmur of severe aortic regurgitation. All right. So let me quickly once more ask you how much you remembered. Tricuspid stenosis, what is the murmur?
Mid-diastolic.
Very good. Tricuspid regurgitation?
And systolic.
Holosystolic or pansystolic, you call it as. You can't listen S1, you can't listen S2. What you listen is only murmur. Z, 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 z. You listen the murmur. That is called pansystolic. Pulmonic stenosis, what is the murmur?
Ejection systolic.
Very good. Ejection systolic. And pulmonic regurgitation?
Graham.
Early diastolic.
Early diastolic, Graham-Steele's murmur. And aortic regurgitation?
Austin Flint.
Murmur. What is the timing of that?
Mid-diastolic murmur.
Mid-diastolic murmur. But this is what you have to remember. Now you're the king in the topic of murmurs. Not only being that, this session should inspire you, to go back to the Davidson or any son that you are studying, Harrison, Davidson, CMDT, or any damn book talks about the same thing. But what is important is, it is not your eyes which should be trained. It is not the vision which is the one that you need to train. It is the audition. Your auditory cortex memory is longer. What you listen is longer many times than what you see, right? Because the visual impulses are millions. Auditory impulses are 1/10 of that. So most of the times, that's the reason, no PowerPoint slides, no whiteboard writing, no videos, only audio. Like Ekalavya, you need to listen, interpret in your brain, remember, reproduce in the exam without the need of any revision. So that is how every day 6 p.m. you have a live session. Not only me, there are a lot of NEET PG toppers, wonderful national faculty. They will all be conducting this live interactive session. Now, let us talk 10 points about mitral stenosis. First, I will rattle out the points. After that, I will check how much you understood. Keep your ears attentive, lend your ears, gentlemen. What is the normal mitral valve diameter? 4 to 6 centimeters square. Severe MS, when do you call? Less than 1.5 centimeters square. When do you call critical? You call critical whenever, 1 minute. Yeah, you call it critical whenever there is less than 1 centimeter square. Then what are the auscultatory findings in mitral stenosis? Typically, when the mitral valve opens, it creates a loud opening snap. That is a classical feature. What kind of murmur is MS? It is a mid-diastolic murmur. Mid-diastolic murmur is mitral stenosis. And typically, it is mid-diastolic, but towards the end of the diastole, it shows pre-systolic accentuation. Suddenly, the sound of it will increase. That is called pre-systolic accentuation. So it's a mid-diastolic murmur showing at the end of the diastole a pre-systolic accentuation. And what is the reason for that? Because in the last 1/3, when the ventricle is getting filled from atria, atrium actually contracts. That atrial systole contributes to the pre-systolic accentuation. That's the reason if there is any atrial fibrillation in a patient of mitral stenosis, this last 1/3 of the diastole, that is the pre-systolic accentuation component, will disappear if there is an atrial fibrillation. That is what you need to remember. Now, how is the first heart sound in mitral stenosis? Loud. How is the second heart sound in mitral stenosis? Loud P2 will be there. Loud P2. Why loud P2 will be there? Because mitral stenosis lead to a high pressure in the left atrium. A high pressure in the left atrium. Who is draining into left atrium? Pulmonic vein is draining into left atrium. That is the reason that lead to high pressure in the pulmonic vein, that lead to pulmonary hypertension. And because of that pulmonary hypertension, there is a loud P2. So loud first heart sound, loud P2. These are the two important features. Now, how do you know that this is a severe mitral stenosis? It is not the loudness of the first heart sound. It is not the loudness of the P2. It is not the intensity of the murmur that talk about the severity. It is the length of the murmur. It is the length of the murmur, which basically talks about the severity. And the opening snap and the second heart sound, between the two, it is called S2OS gap. Shorter this gap between second heart sound and the opening snap, more severe is mitral stenosis. Longer is the gap between second heart sound and opening snap, milder is the mitral stenosis. That is what you need to remember. Similarly, longer the mid-diastolic murmur of mitral stenosis, more severe is mitral stenosis. This is what you need to remember. Then how do you treat? We do percutaneous mitral balloon valvotomy is the important treatment. That is, we pass a balloon percutaneously and open up the valve, which is stenotic. Now, the very common question, three contraindications for the percutaneous mitral balloon valvotomy. If the mitral valve is severely calcified, you can't use a balloon to open it up. Similarly, if it is a very severe mitral stenosis with MR, you can't. If the MR develops in a case of MS, you can't do balloon valvuloplasty. Similarly, if there is any thrombus in the left atrial appendage, in a severe MS, you cannot do. So these are considered to be some of the important contraindications is what you need to remember. So, doctor, I finished my summary. Shall I ask you questions? How much you heard? Are you ready?
You're ready.
Yes. What is the normal mitral valve diameter?
4 to 6 centimeters.
Very good. When do you call severe MS?
1.5 centimeters square.
Very good. When do you call critical MS?
It is like 1 centimeter square.
Very good. And what are the auscultatory findings? 1, 2, 3, 4. First, tell me what is the murmur?
Mid-diastolic murmur.
Yeah.
Very good. And what is the nature of it? Mid-diastolic murmur.
Loud.
I mean to say anything about
Pre-systolic accentuation.
very good. And when will pre-systolic accentuation will be lost?
In atrial fibrillation.
Very good. If there is an atrial fibrillation, it will be lost. And what decides the severity of mitral stenosis?
Length of the murmur.
And it is inversely proportional to It is inversely proportional to?
So,
Duration of murmur.
Hmm?
Duration of murmur.
Right. Duration is a determining factor. The more severe the MS, the longer is the murmur. I fully agree. But what is it inversely proportional to? Just before I told, S to OS gap,
yes, sir.
the gap between second heart sound and opening snap. How will you remember? See, when is mitral stenosis is a big issue? When the left atrium is emptying into the left ventricle. What is the meaning of left atrium emptying into left ventricle? That means left ventricle goes into diastole. All right.
Yes, sir.
And when will diastole occur? At the end of systole. At the end of the systole. At the end of the systole, what happens? Aortic valve closes. How do you know aortic valve closed? You hear second heart sound. So the S2 is a indicator of the end of the systole and the beginning of the diastole. And the beginning of the diastole. And the moment the diastole happens, the stenotic valve, the blood has to gush out of it. It leads to opening snap. So between S2 and this opening snap, if the duration is shorter, what is the meaning of that? That means after the systole, end of the systole, diastole is beginning immediately. That is the reason you are listening opening snap. Why are you hearing it? Why is it happening immediately? Because there is a very tight mitral stenosis and there is a lot of blood behind the mitral valve, which is causing a high pressure behind the mitral valve. That is the reason the moment the systole is over, immediately it is opening and snapping. So that is the reason when you heard that opening snap, after the end of the systole, which is identified by S2. So between the S2 and the opening snap, the distance is shorter, means there is a lot of pressure behind the mitral valve. That means there is a more severe mitral stenosis. So I think you understood partly at least. Now tell me once more, severity is decided by what are the two factors?
The length of the murmur
Very good.
and the gap between S2 and opening snap.
Very good. And shorter the gap,
The more is the severity.
very good. More is severity. I'm so happy. Now quickly tell me, what are the three contraindications you don't want to do percutaneous mitral balloon valvotomy?
One is calcification, sir, and stenosis with regurgitation, and
Very
other thing, thrombus in the left atrium.
Wonderful, wonderful. I'm so happy with the kind of revision that we are having today. Good, doctor. Now, let us go to some other points in general medicine. We had good amount of cardiology, and we'll try to go to something else. A bit of nephrology. Let's talk about. Now, let me start with the topic of SLE. SLE, right? I will tell 10 points and once more ask you the questions. Otherwise, you will forget, right? Please lend your ears. Auditory memory is longer lasting and interactive than the visual memory, right? Now, SLE is which hypersensitivity? Type 3. Then typically SLE and the number of X chromosomes, they have a relation. Suppose the SLE happened at Turner syndrome, Turner has only 45XO. It is typically less severe. Whereas if SLE occur in Klinefelter, that is XXY, it has 2 X chromosomes, so it is more severe. So the severity of the SLE depends upon the number of X chromosomes is what you need to basically remember. Then another important thing that you need to remember is clinical features. Malar rash, butterfly rash without nasolabial sparing, that is a classical feature. Now, without nasolabial folding, that is nasolabial fold is not involved. Why is this important? There is also a butterfly rash in seborrheic dermatitis, but there the nasolabial fold is also involved, whereas in SLE, it is not involved. That is the reason you need to remember. Then malar flush is not only a feature of SLE, it is also seen in mitral stenosis also. That's the point you need to remember. Then, what is the best screening test? ANA. And what is the one which correlates with disease activity? dsDNA. What is the most specific antibody? Anti-Smith antibody. And whenever SLE is part of the mixed connective tissue disorder, what is the antibody? Anti-RNP, RNP, ribonucleoprotein antibody is the one which you see whenever SLE is a part of the mixed connective tissue disorder. Then, which serological marker of SLE is correlated with psychosis and CNS lupus? Anti-ribosomal P antibody is what you need to basically remember. Then, whenever SLE has lupus cerebritis, which antibody? Anti-neuronal antibody. SLE with photosensitivity, it is the anti-Rho antibody which is associated. And SLE, if the mother is having, she is pregnant and the baby is having, will develop heart block because of the AV nodal block. Which antibody is responsible? Anti-Rho antibody is responsible, is what you need to remember. So anti-Rho can lead to neonatal lupus, is what you should remember. Then, which serological marker in SLE reduces the risk of developing lupus nephritis? Reduces. It's a good news if it is there. It is the anti-law, anti-law antibody, which is SSB antibody, is what you need to remember. Then there is an anti-histone antibody. What is the significance? Drug-induced lupus, you have anti-histone antibody. Tell me 4 drugs that lead to the drug-induced lupus. Remember SHIP, 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 right? So S for sulfonamide, H for hydralazine, I for isoniazid, P for procainamide. Out of all this, it is the procainamide which is the most common cause of the drug-induced lupus. Where do we use procainamide, doctor? We use it in the Wolff-Parkinson-White syndrome. Whenever they have a severe atrial fibrillation, supraventricular tachyarrhythmias, there to manage that we give procainamide. But that procainamide is the most common drug associated with drug-induced lupus, is what you need to remember. Now, there are 2 things which are found in SLE, but not in drug-induced SLE. What are those 2? Lupus nephritis is not seen. Lupus nephritis is a feature of SLE, not drug-induced SLE. Then lupus cerebritis. Lupus cerebritis is a feature of the SLE, but not drug-induced SLE, is what you need to remember. Now, a lot of things we read, doctor. almost all 10 points, still just 5-6 points. Then I will come to the Q&A, question and answer game with you. Anti-phospholipid antibody in SLE. So there is a triad of clinical features, doctor. Every time they ask in the entrance, what is that? It's also called APLA syndrome, anti-phospholipid antibody syndrome. Number one, it leads to recurrent abortion, and at the end of the first trimester, or at 34 weeks, there is an unexplained intrauterine death because of this APLA. And how do you diagnose APLA syndrome? You do ELISA for the cardiolipin antibody. You do ELISA for the beta-2 glycoprotein antibody. And also there is a test called dilute Russell Viper Venum time test. Dilute Russell Viper Venum time test. It is the specific test and used as a screening method to identify the lupus anticoagulant is what you need to remember. Then very important thing about the APLA syndrome is why these recurrent abortions happen in APLA syndrome. It is all because APLA syndrome is a prothrombotic state. There's a lot of clot formation tendency. So clots form in uterine artery. They compromise the blood supply to fetus. That lead to recurrent loss of the fetus. That is the reason the most important treatment you should not forget is lifelong low-dose aspirin, 75 milligrams. Lifelong low-dose aspirin, 75 milligrams is the treatment in APLA syndrome is what you need to remember. Then, typically, those who are having SLE can develop anti-erythrocyte antibody, and that can lead to autoimmune hemolytic anemia. And how do you identify that? If you take peripheral smear in a SLE patient, if you find spherocytes, don't forget, examiner is asking you, do you know about anti-erythrocyte antibody? So anti-erythrocyte antibody lead to autoimmune hemolytic anemia, where peripheral smear has spherocytes in case of SLE is what you need to remember. So now, doctor, I'm going to quickly ask you the questions on what all that we read. Are you all ready?
Yes, sir.
Yes. What type of hypersensitivity SLE?
Type 3.
Very good. Between Turner-Klinefelter, who has more severe SLE? Klinefelter. Very good. And what is the difference between the butterfly rash of the SLE versus seborrheic dermatitis?
Natural fold is not involved in SLE. That is involved in
Dermatitis. It's involved.
Very good. And what is the cardiac condition that can lead to a malar flush-like SLE? Yeah.
the Mitral Stenosis, sir.
Very good. Very good. What is the best screening serological marker of SLE?
ANA.
Very good. And what marker correlates with the disease activity?
Double
Yes. What correlates with disease activity? Yes, doctor.
Anti-ribonucleoprotein, sir.
Very good. Double-stranded DNA. What are the most specific antibody? What is the most specific antibody? Haripriya, Karnakar, Manoj, anybody?
SSP antibody.
Most specific is anti-Smith antibody. And which serological marker of SLE you see whenever SLE is part of mixed connective tissue disorder?
Anti-Smith antibody, sir.
Anti-RNP, sir.
Very good. Anti-RNP antibody. Very good.
Yes.
And which antibody is associated with psychosis and CNS lupus?
Anti-neuronal antibody.
Anti-neuronal antibodies with lupus cerebritis, but psychosis and CNS lupus? Yeah? Psychosis and CNS lupus, anti-ribosomal P antibody, okay? And which correlates with photosensitivity?
Anti-Rho antibody.
Very good. And congenital heart block in neonatal lupus?
That is also anti-Rho, sir.
Very good. It is also anti-Rho, which is also called SSA. SSA. Now, which serological marker reduce the risk of nephritis?
Anti-La antibody.
SSB. Very good. Give me the 4 drugs that lead to lupus, drug-induced lupus.
Tip sulfate, hydrogen,
One TB drug.
Isoniazid.
Procainamide.
Procainamide.
Very good. And what is the common indication for procainamide? Why do you give that?
In WPW syndrome.
Very good. In WPW syndrome. Excellent. And what are the 2 features that are there in SLE but not in drug-induced SLE?
lupus nephritis and lupus cerebritis.
Super, super, super. Now, how do you diagnose antiphospholipid antibody syndrome? You do ELISA for which antibodies?
Cardiolipin antibody.
Very good. And beta-2 glycoprotein. Okay, beta-2 glycoprotein. What is the specific test which is also used to screen lupus anticoagulant? Dilute, Russell, Viper, venom time test. Okay. Now, a Apla syndrome lady will be asked to take lifelong which drug?
Aspirin.
Low dose aspirin.
75 mg.
Very good. 75 milligrams of low dose aspirin. SLE patient has spherocytes in the peripheral smear. What do you, which serological marker you want to look for?
Please repeat, sir.
Anti-erythrocyte antibody.
Very good. Anti-erythrocyte antibody. Super, super. I'm so happy, doctor. Now let us quickly go to another 10 points about SLE. Typically, SLE rash, let us look at the manifestations. SLE rash, it involves a bridge of the nose, cheeks, and nasolabial fold sparing. All right. Then the subcutaneous lupus erythematosus. What is a close differential diagnosis for subacute cutaneous LE psoriasis? Because both psoriasis, subacute cutaneous LE, both of them show irregular red scaly patches. But psoriasis has no photosensitivity. SLE, subacute cutaneous lupus, SCLE, it has photosensitivity. Then chronic cutaneous lupus erythematosus. In that you get circular lesions with a hyperpigmented periphery and a hypopigmented central part. That is what you need to remember about chronic cutaneous lupus erythematosus. What is the other name given for the chronic cutaneous lupus, doctor? Discoid lupus erythematosus. And typically in this, you get alopecia. But what type of alopecia? Non-scarring alopecia, not the scarring one. Lot of times students do this mistake. SLE means inflammation, means scarring. That's how they try to guess in the exam. But you should know all causes of scarring and non-scarring alopecia. So chronic cutaneous LE lead to non-scarring alopecia is what you need to remember. Now, which system in the body most commonly involved in SLE? It is the musculoskeletal system. That is arthritis because of the SLE is very common. What is the specialty of that arthritis in SLE? Non-erosive arthritis. Agar erosions hai to it is not SLE. Non-erosive arthritis, even though it is an inflammatory arthritis, you don't find erosions. Whereas rheumatoid arthritis like conditions, erosions are seen, but never in SLE. And what is the treatment of the arthritis of SLE? We give topical steroid plus hydroxychloroquine. Hydroxychloroquine is what you need to remember. Now, a very common differential diagnosis you should remember. A 40-year-old presented with dyspnea with chest X-ray showing bilateral hilar lymphadenopathy. Examiner will ask you, what is your diagnosis? You should jump and answer sarcoidosis. And in sarcoidosis, you get purple lesions on the skin. But the name of those purple lesions is lupus pernio. But lupus pernio has nothing to do with SLE. Name is lupus, but it has nothing to do with SLE. Lupus pernio are those purple lesions that you find in sarcoidosis is what you need to remember. Then lupus vulgaris is another entity. It has nothing to do with lupus. Lupus vulgaris is about tuberculosis. Lupus vulgaris is about TB. Lupus pernio is about sarcoidosis. Nothing to do with SLE. Now, one of the favorite question. Serositis. Serositis in the SLE. Typically in the lung, serositis will lead to pleuritis. And there is one thing in serositis in SLE called shrinking the lung syndrome. Shrinking the lung syndrome. So many times this question was asked. Where do you see shrinking lung syndrome? SLE. Similarly, the most common lesion in the heart whenever the serositis happens is pericarditis. And least common is in the heart because of the serositis in SLE. Litmus endocarditis is what you need to remember. Now, a very common thing is pericarditis lead to chest pain, pleuritis lead to chest pain. How do you differentiate? If it is a chest pain of pleuritis, if you take inspiration, it will worsen. Whereas inspiration has no relation with worsening, then that is suggestive of pericarditis. That's the point. Then, how do you identify pericarditis on ECG? Multiple leads, V1, V2, V3, multiple leads will show ST elevation, multiple leads. And what type of ST elevation? ST is elevated, but it is called upward concave pattern of ST elevation suggests pericarditis is what you need to remember. Now, a few points about Litmus-Sachs endocarditis. What is Litmus-Sachs endocarditis of SLE? It is a sterile endocarditis. That means there are no infections. It is not any organisms. It is the fibrin which is depositing, responsible for Litmus-Sachs is what you need to remember. And a lot of times Litmus-Sachs lead to the development of mitral regurgitation. Mitral regurgitation. Now, a common MCQ in entrance is there any role for giving steroids to treat it? Litmus-Sachs? No, there is no role because it is the fibrin deposits on the cardiac valve which is responsible is what you need to remember. Then, the next important feature of SLE is oral ulcers. aphthous ulcers. It can be generally painless, but it can be painful. And if there are recurrent oral ulcers, they can be controlled with topical steroid. But whenever recurrent aphthous ulcers are happening in the oral cavity and vulva, or in a male patient, recurrent aphthous ulcer in the oral cavity and scrotum, then what is that connective tissue disorder that should come to your mind? Behçet's disease. Recurrent orogenital ulcerations is the hallmark of Behçet's disease, is what you need to remember. Then, let us talk about the synovitis. Typically, what kind of arthritis do you see in SLE? Non-deforming arthritis. Whereas if you take conditions like psoriasis, it is a very, very deforming arthritis. Whereas SLE arthritis is synovitis with absent deformities. And it is a asymmetrical joint involvement. And it involves proximal interphalangeal joint, wrist and knee. That's the point you need to remember. And what is the meaning of rupus? R-H-U-P-U-S, rupus. Rheumatoid arthritis and SLE together is called rupus. Lupus nahi, rupus. And how do you treat rupus? If there are severe joint pains, give steroids. But what is the important side effect of a long-term steroid? It can lead to avascular necrosis of bone. Avascular necrosis of bone. That is the main challenge while you are treating the patient. SLE patient came with arthritis, you are giving steroid, but suddenly joint pain is increasing in spite of giving steroids. You should think of possibility of a avascular necrosis, and that is investigated by doing the MRI is what you need to remember, MRI. Then let us talk about the brain involvement. Typically, what is the most common presentation of the brain CNS involvement in SLE? There is a defect in cognition. Any learning defect, we should check whether it is CNS involvement. Then, what are the clinical presenting features of lupus cerebritis? Cerebral edema, headache, seizures. These are three things you should remember. And whenever there is any psychosis, I already told you psychosis, and which serological marker? Anti-ribosomal P antibody is what you need to remember. Then finally, renal involvement. If I ask you a question, why SLE patients die? In whose hands do they die? They die in the hands of a nephrologist. Important cause of the death in SLE is active lupus. So if you do microscopic examination of urine, because of the lupus nephritis, you find microscopic hematuria, proteinuria, nephrotic syndrome, end-stage renal disease. That is what you need to remember. And how do you diagnose lupus nephritis? And how do you classify the severity? You do biopsy. Obviously, when you do biopsy, there is something which is very dirty thing examiner expects you to remember in exam hall. Class 1, class 2, class 3, class 4, class 5, class 6. Oh my God. We feel like crying when we listen to so many classes and examiner is going to quiz us. We have to buttify all these things, but there's no other way. But anyway, let us enjoy buttifying that. Class 1, minimal mesangial lupus nephritis. Class 2, mesangial-proliferative lupus nephritis. Class 3, focal lupus nephritis. That means less than 50% glomeruli are involved. Class 4, diffuse lupus nephritis. More than 50% of glomeruli are involved. Class 5, membranous lupus nephritis. Class 6 is advanced sclerosing lupus nephritis. Now, 3 points you should remember. What is the most common type of all these classes? It is the class 4, that is diffuse diffuse lupus nephritis is most common type of lupus nephritis. And if you do a PAS staining, what are the type of lesions in lupus? They're called viral loop lesions. Viral loop lesions is what you need to remember. Another favorite question. If you do immunofluorescence in lupus, which class of immunoglobulins do you find on immunofluorescence? You find IgA, IgG, IgM, C1, C3, everything you will find. That's called full house effect. Full house effect on immunofluorescence is what you need to remember. Now, we are almost reaching the end, don't worry. This SLE story will be over. If you look at anemia, I already told you, spherocytes is a marker of autoimmune hemolytic anemia is what you need to remember, right? Now, there is one entity called hereditary spherocytosis. So how do you know whether spherocytes in the peripheral smear are due to hereditary spherocytosis or other causes? Hereditary spherocytosis is a congenital defect in the RBC cell wall due to the spectrin deficiency. It is not autoimmune. That's the reason direct Coombs test is negative if it is hereditary spherocytosis. Whereas it is positive if it is due to autoimmune hemolytic anemia. That's what you need to basically remember. So, doctor, before we say goodbye, let me quickly take you all for a quick quiz. Are you all ready?
Yes, sir, ready.
Let me check how much you are using your auditory cortex. Now, how do you differentiate psoriasis from subacute cutaneous LE? Psoriasis versus subacute cutaneous LE. Who is going to give me the answer?
Photosensitivity is there for
Very good.
no photosensitivity for psoriasis.
I am really, really very happy that you learned that point. Very good, doctor. Superb, superb, superb. Then, the next question I like to ask you is, what type of alopecia in chronic cutaneous LE?
Non-scaling.
Non-scan. Very good. And what is the most common system involved in SLE? Very good. Musculoskeletal. Where do you see lupus pernio?
Sarcoidosis.
Very good. And tell me two things in lung because of serositis. Serositis, lung involvement in SLE.
Shrinking lung syndrome.
Very good. And pleuritis.
Right.
And in heart,
Litmus endocarditis.
Diabetes.
very good. Pericarditis, Litmus sac. Very good. I'm so happy. Pleuritis versus pericarditis both cause chest pain. How do you differentiate?
If it worsens with deep inspiration, it is pleuritis, sir. If it decreases, pericarditis.
Very good. And on ECG, if there's a pericarditis, what do you expect?
Multiple leads ST elevation.
Very good. ST elevation with upward concave pattern. Yeah. Is there any role for the steroids in the treatment of Litmus sac?
No role.
No use of steroids.
Yeah. And Litmus sac is fundamentally what? What deposits?
Fibrin deposit.
Deposition.
Very good. Fibrin deposition. Fibrin deposition. Very good. Now, recurrent orogenital ulcerations. What is that condition? What is it? Very good. Besets. Excellent. And suppose if a patient of the SLE joint pains, receiving steroid, it is not resolving but worsening. What do you expect?
Avascular necrosis.
And how do you evaluate?
MRI.
Beautiful. Then what are the most common CNS involvement in SLE?
Cerebral edema.
Is also
Cognitive defect.
In cognition.
Okay, defect in cognition. Yes, you said cerebral edema, right? That is one of the features of the lupus erythematosus. Cerebral edema, headache, and seizures. Now, psychosis is associated with which antibody?
Anti-ribosomal P.
Very good. And what is the most common type of lupus nephritis? Which class?
4.
Very
4.
good.
diffuse.
And what is 1? What is 2, 3, 4, 5? What is 1?
Minimal mesangial.
Class 2?
Mesangial polycytic.
Class 3? Focal.
Focal.
That means, what is the meaning of focal?
Like
Less than 50% of glomeruli. And class 4?
Diffuse.
Class 5?
membrane.
Membranous.
6?
Advanced sclerosing.
Very good.
One.
And what are those classical lesions demonstrated on past staining in lupus nephritis?
Wire.
Wire loop lesions.
Very good. Which immunoglobulin deposits on immunofluorescence?
IgA, IgG, IgM, C1 and C3.
Very good. Very good. Beautiful. And how to differentiate SLE, autoimmune hemolytic anemia versus hereditary spherocytosis, spherocytes?
Direct Holmes test.
Holmes test is negative in hereditary cirrhosis.
Beautiful, beautiful. So that is all the story, doctor. I hope you all enjoyed this wonderful evening, and every day, let us all study together. Please also inform your classmates and friends. And have you enjoyed the session?
Yes, sir.
Yes, sir.
Yes, sir. Thank you very much, sir.
And
Yes, sir.
try to enjoy it. You know, there is no more happiness than sitting with a group of students and spending an interactive session for an hour. Wow, the richest experience of the life. I feel like a billionaire whenever I get an opportunity to sit with the students and learn. You're all the top consultants. And let me tell you, in the past 22 years, I had the fortune of spending time with almost 2 lakhs medical students and doctors attended online, YouTube, here and there. And I had a God-given opportunity to inspire the wonderful mind. Some of them are top consultants. And some of my students also who are great teachers, and they're all toppers in entrance. They love to come and conduct sessions like this. If you guys promise to come to these sessions, and shortly we are launching an app next week called Wongo. Wongo app is like social audio app. The moment you enter, there are multiple audio chat rooms, and you can call your friends. You too can start a chat room. You can study together, and you can make friends, study mates. Only audio, no video, no chatting, texting, nothing. So once that Wongo app is launched, I will also send a share to you. Please do join. Thank you very much. Once more tomorrow evening, 6 o'clock with Dr. Murali.
Thank you, sir.
Yes, sir.
Yeah, thank you.
Thank you, sir. Thank you, sir.